Good morning to everybody. Now we will start a new chapter, mineral metabolism. So long we have seen that different type of macromolecules, vitamins are required for normal functioning of the cell, its growth and development. Likewise, there are minerals which are essential, very much essential for normal functioning of the cell. Today we will discuss calcium metabolism. We will discuss this under these headings: introduction, sources, RDA, recommended daily allowance, absorption, biochemical function, regulation of body calcium level, and clinical significance. This calcium is very important. You are going to get a long question. Definitely you will get one question. A long question you may get. You may get short questions like from the clinical significance. You can get TSMC as short note. Then clinical based questions on this TSMC you may get. Small question can be given from this topic: hormonal regulation of blood calcium. Okay, these things all we see now. Very easy, but as it is chemistry, nothing is there to see and remember. So you have to memorize, write again and again, you will be able to memorize it. Mineral, a lot of minerals are there. Some of the minerals, they have several vital functions. And these minerals are absolutely essential for existence of living cell. They may be classified as those which are required a bit larger quantity. They are classified as principal elements, and those which are required in less amount, they can be classified as trace elements. Okay. Now, those minerals which are required 100 milligram per day or more, they comes under principal elements, and less than 100 milligram they comes under trace elements. So, calcium, phosphate, magnesium, sodium, potassium, they comes under potassium chloride and sulfur. They comes under principal elements. See, here I have not put any etc. etc. I so you have to write these only. You cannot add some mineral, or you cannot move some mineral. For example, if you like to give 2 or 3 examples, then you can write etc. But better to give these elements in full. In trace elements, some are required very frequently. They are classified as essential trace element. Do not confuse with principal element. Essential trace element, they are the iron, iodine, copper, cobalt, then chromium, fluorine, manganese, molybdenum, selenium. Next group is possible essential trace element. Possible. These are nickel, vanadium, cadmium, barium. If there is not mass also, the body will not have some problem. And next is not essential trace element. They are actually doesn't have much function in the body, but sometimes they are required. Calcium, this is a very important mineral. Total body calcium for adult male is 1 to 1.5 kg. 1.5 kilogram because body has bones and bones are formed by calcium. That's why this much large amount is there in body. Now, out of this large amount, about 99% is found in the bone and teeth, and remaining 1% is outside skeletal tissue. And these 1%. So the serum calcium, it belongs to that 1% only. So out of this 1%, around 50% remains as ionized form, and this is the portion which come into play different biological function of the body. 40% remains protein bound, it is non-diffusible. So, and 10% is calcium complex, 10% calcium is complex to citrate, phosphate and bicarbonate. Sources, these are predominantly present in milk and milk product. Also present in meat, egg, fish, and vegetables like cabbage, beans, green vegetable. Green vegetable is a source where every vitamin is present more or less. Every mineral is present more or less. Okay. So green vegetable is very important. All of you must take green vegetable. Cereals and pulses. Daily dose RDA means recommended daily allowances. Adult minimum 800 milligram per day. Children, they are in a growing state, so they will need more. That's why even they are small, they need more, 800 to 1200 milligram per day. Infants, they need 300 to 500 milligram per day. Pregnancy, lactation and postmenopausal period, they need a large quantity of vitamin calcium, around 1500 milligram per day. Now, source of calcium is dietary. Once we take, it is absorbed from the first and second part of the duodenum against concentration gradient. That means it is absorbed by a active mechanism. Vitamin D increases calcium absorption by increasing binding protein in intestinal cell. Vitamin D, its active form is 125 dihydroxycholecalciferol, also called calcitriol. This calcitriol is synthesized in the kidney, but it acts on intestinal wall. Okay, it increases the calcium binding protein for absorption of calcium in the intestinal wall. Parathyroid hormone. Parathyroid hormone increases calcium synthesis, calcitriol synthesis, and thereby increase calcium absorption. Parathyroid hormone, very important hormone for calcium regulation of for important hormone for the regulation of body calcium. So, but this parathyroid hormone, it doesn't have direct action on calcium absorption in the intestine. It acts indirectly through calcitriol. Acidity, lactose, lysine, arginine favors calcium absorption. Remember these things. Factors inhibiting calcium: phytate, oxalate, they form insoluble complex with the calcium. So phytate is plant abundantly present in maize. Okay. Now, if you take milk and maize together, the calcium present in maize will be converted into insoluble calcium phytate. So, it is a great loss to take these two food together. High dietary phosphate. Again, phosphate, remember, up to certain concentration of calcium and phosphate, there is facilitation in calcium absorption by the phosphate. It is 1:2 to calcium is to phosphate. Calcium is to phosphate. If it is 1:2 to 2:1, within this range, it will help absorption of calcium. But if it goes higher, if phosphate concentration is higher, it will form a calcium phosphate. It will chelate the phosphate calcium as calcium phosphate. So it is insoluble. It will not be absorbed. Then fatty acid, free fatty acid, it forms insoluble calcium soap. It happens in fat indigestion. So there calcium is lost in the intestine. It doesn't get absorbed. High pH means alkaline pH. High dietary fibers, they hamper calcium absorption. This is the previous one. Normal blood calcium is 9 to 11 milligram %. Just see, 9 to 11, only 2 points. There is difference. It is such a molecule, it is such a mineral that deficiency of which will produce a deleterious effects and life threatening condition. Whereas its range is very narrow, so its regulation is tightly controlled. Okay. Factors regulating plasma calcium level. This is also called homeostasis of calcium, also called hormonal regulation of calcium. Please note, please remember, very important, you will get question. Now, here is our serum calcium level. 9 to 11 milligram %. This is maintained from 3 sources. One, intestinal calcium, then your from calcium from bone, then is there renal calcium. Renal tubular calcium. Okay. So from these 3 sources we get. Now see, if it tends to go down, if there is deficiency in intestinal calcium, that means there is no adequate intake of calcium, then what happens? As it is very dangerous molecule and it has to be maintained in this range, the bone calcium and renal calcium, it comes into play. But kidney doesn't have much calcium. Okay. So the maximum calcium is gained from the bone. That results in resorption of bone. Resorption. That means demineralization of bone. So bone becomes weak. Is not it? So that's why dietary calcium is very important. Now this intestinal calcium, after taking from duodenum, it gets absorbed. This is regulated by calcitriol. Calcitriol, how it regulates? It increases the calcium binding protein. So it will give, calcitriol will promote calcium absorption. What is calcitriol? 1,25 dihydroxy cholecalciferol. This is active form of vitamin D3, active form of vitamin D. So, calcitriol is the main person who helps calcium absorption. Now, when this calcium tries to go down, the parathyroid hormone when there is low calcium level, immediately parathyroid hormone is released. Calcium has a low calcium level has a influence of releasing parathyroid hormone, negative feedback. So calcitriol is secreted, it increases intestinal calcium absorption. This is what? This is nothing but the vitamin D, active form. Okay. Now, intestinal calcium is mainly absorbed due to the increase of calcium binding protein stimulated by calcitriol. So, parathyroid hormone, it indirectly stimulates intestinal calcium absorption. Now, parathyroid hormone here, what happens? Parathyroid hormone, if there is inadequate intestinal calcium, this parathyroid hormone, what it does? It stimulates osteoclast. Osteoclast, two cells come into play in calcium metabolism. It is osteoblast and osteoclast. Osteoclast. Now osteoclast, they are stimulated, they causes bone resorption. They demineralize the bone. Okay. Now this released calcium in the bone, they are shifted to the serum and serum calcium level is maintained. Okay. Now similarly in bone, again another hormone is there, calcitonin. Calcitonin. This is secreted by the parafollicular cells of thyroid gland. Calcitonin has just opposite function of parathyroid hormone. It doesn't allow demineralization. It mineralizes the bone. The calcitonin, it stimulates osteoblast. Osteoblast is responsible for bone mineralization. Osteoclast is responsible for bone demineralization. Okay. So calcitonin, it stimulates, it promotes activity of the osteoblast and mineralization of the bone and bone remodeling. So it has lowering activity on serum calcium. So here this one, when it goes down, this part comes active, and when it goes high, this calcitonin part becomes active. So calcitonin has anti-parathyroid activity. Then PTH in renal tubular cell. Here is also again calcitriol also promotes osteoblast activity. Now in renal tubule, two function happens. The parathyroid hormone This promotes renal tubular calcium reabsorption. Number one. Number two, it stimulates production of calcitriol, 125 dihydroxycholocalciferol. So this calcitriol, it is produced in kidney. When there is renal damage, there is inadequate production of calcitriol. Okay, so calcitriol synthesis, it increase reabsorption of renal calcium and increase calcitriol synthesis. Okay, so blood calcium, when it tends to decrease, parathyroid hormone is released immediately. It increases calcium absorption from the intestine through increased activity of calcitriol. Parathyroid hormone, it causes demineralization of the bone, thereby released calcium is transported to the serum and serum calcium level is maintained. Parathyroid hormone, it causes reabsorption of renal tubular calcium and increased synthesis of calcitriol. By this mechanism, parathyroid hormone, it maintains the blood calcium level, and by this way it is maintained. So here three hormones are responsible: calcitriol, parathyroid hormone, calcitonin are major factors of calcium homeostasis. Active form of vitamin D is calcitriol. It induces synthesis of calcium binding protein in the intestinal cell, so increase calcium and phosphate absorption, stimulates osteoblast activity and promotes calcification and remodeling of bone. Parathyroid hormone it causes demineralization of bone by stimulating osteoclast activity. Parathyroid hormone increases renal reabsorption of calcium and stimulates production of 125 dihydroxycholocalciferol. Increase intestinal absorption of calcium. Now here you see hypocalcemia, there is low calcium level, stimulates parathyroid gland. This is the thyroid gland situated in the front of the neck. Here in the neck, front of the neck, there is a gland called thyroid gland. It has two lobules. Like that. Two lobules are there in each side of trachea. If we turn back side front, there is two glands like that situated in the parathyroid gland. In anatomy they will show you. Okay. Now these are situated in the back side of the thyroid gland. So in this is the parathyroid gland is responsible secreting parathyroid hormone. So parathyroid hormone released in the blood, it comes and goes to the bone, it activates osteoclast activity, calcium and phosphate ions are released and they are transported in the blood, so it has gone to blood. Now in intestine, it increases calcium absorption from blood food, then the calcium is shifted to the blood. In kidney, it promotes activation of vitamin D, that means calcitriol formation. Okay, then increase calcium reabsorption. So by this mechanism, blood calcium has gone up. Now when there is a rise in blood calcium level, what it does, it inhibits parathyroid hormone release. It has a negative feedback on parathyroid hormone, negative feedback. Okay, when it increases, it inhibits the parathyroid hormone release. So thus calcium homeostasis is maintained in the body. Parathyroid hormone, it is a single polypeptide chain having 84 amino acid. Single polypeptide chain molecular weight 95,000. Now it is secreted as pre-pro-parathyroid hormone. Pre-pro-parathyroid hormone. Now after that is some sequence of amino acid are clipped and forms pro-parathyroid hormone. Pro-parathyroid hormone. Okay. Then further removal of amino acid sequence causes parathyroid hormone, which is active. Active parathyroid hormone. Okay. Now, how does it work? Mechanism of PTH action. Now this is a cell membrane. Parathyroid hormone, what happens? It binds with the receptor. Parathyroid hormone binds with the receptor over the cell membrane. That causes activation of adenyl cyclase. Adenyl cyclase. This is a enzyme. This causes release of cyclic AMP. When you read cell signaling, you will come to know clear about this. For the time being, you remember that adenyl cyclase releases cyclic AMP. This cyclic AMP causes increase intracellular calcium. This intracellular calcium causes phosphorylation of one enzyme called protein kinase. In phosphorylated form, protein kinase is active. Okay. Now this protein kinase, it activates other enzymes, and the physiological function of PTH is done with this mechanism. Okay. Now with this mechanism, the physiological function of parathyroid hormone is. Now what about the action in bone? So as action on bone. In bone, it stimulates osteoclast activity, activates enzyme pyrophosphatase and collagenase, promotes pyrophosphatase and collagenase. So by the function of pyrophosphatase, there is release of calcium ion in the bone matrix. Then this calcium is brought to the blood circulation. Okay. Now this is the way how it functions in the bone. Now its intestine increase absorption of calcium by increasing the activity of calcitriol and absorption of calcium and phosphate. In kidney, it increases reabsorption of tubular calcium and increases synthesis of calcitriol. Now next hormone, this is calcitonin. Calcitonin is secreted by parafollicular cells of parathyroid hormone. It is a polypeptide of 32 amino acid. By action it is anti-PTH. So already we have discussed, it is anti-PTH. It activates osteoblast and causes mineralization of bone and remodeling. It prevents excretion of calcium, the decreased bone desorption and excretion of calcium, has decreasing activity on serum calcium. Parathyroid hormone, it reabsorbs the calcium from the renal tubule. Calcitonin, it increases the excretion of calcium in the urine. Its activity, its tendency is to lower the calcium level. Biochemical function, bone and teeth formation, calcium and phosphate, it forms hydroxyapatite, and hydroxyapatite is mineralized by calcium and causes bone mineralization. Muscle contraction, increase action of the actin and myosin, thereby facilitating excitation and contraction coupling. Calcium regulates, it is a coagulation factor 4. Calcium binds with prothrombin and helps conversion of prothrombin to thrombin. See, when we give blood transfusion to the patient, in the blood bottle there is anticoagulant which precipitate calcium. Now when we give transfused blood, that anticoagulant also it goes into the blood. So when we transfuse more than 2-3 bottles of blood in a patient, his serum calcium level, it goes down. Okay? So he will have some symptoms, spasm, the symptoms of hypocalcemia. Okay? That's why when large amount of blood, few bottles of blood needed to be transfused, we have to give calcium gluconate along with the blood transfusion. Otherwise, patient will have bleeding disorder or signs of hypocalcemia. So, this is the coagulation factor 4. Integrity of cell membrane, it maintains, responsible for permeability of cell membrane. It acts as second messenger for some hormones like epinephrine, glucagon. It activates some enzymes, ATPase, adenyl cyclase, pyruvate kinase, pyruvate hydrogenase, pyruvate carboxylase, etc. It is responsible for nerve transmission, nerve impulse transmission, involved in secretory processes like endocytosis, exocytosis, cell motility through microfilament and microtubular activity. Release of certain hormones are dependent on calcium like insulin, vasopressin, parathyroid hormone. On heart, calcium exerts a prolonged systolic action. Now, disease state, hypocalcemia, it produces a life-threatening condition called tetany. Tetany. It is tetany. Remember, it is tetany, not tetanus. Tetany is produced by hypocalcemia. Tetanus is produced by toxins of bacteria, Corynebacterium tetani. Corynebacterium tetani. Thus, tetanus occurs when there is a cut. If it is contaminated with Corynebacterium tetani, that will produce neurotoxin that will cause tetanus. Okay. So this is not tetanus. This is tetany. Now in hypocalcemia, when it goes down to 7 mg/%, there is a clinical sign symptoms appears of hypocalcemia, characterized by neuromuscular irritability, convulsion, carpopedal spasm, and it appears, when it appears, there are two signs become positive. These are Vostek sign and Clausius sign. What is that? From this you may get a clinical case oriented question also. Now let's see what is Vostek sign. Vostek sign is, it is the nerve becomes hyper irritable due to loss of low calcium level. So if you tap, now the facial nerve surface marking is just in front of tragus, just in front of tragus. So if you tap it like that, see, normal case if you tap like that, you don't find any fasciculation or contraction here. But in case of hypocalcemia, if tetanus is there, tetany is there, then tapping of this facial nerve will cause spasm or fasciculation of the facial muscles. Okay, this is Vostek sign. And Clausius sign, it is when you tie a BP cuff on the arm and raise blood pressure, pressure in the cuff above systolic. Within 3 minutes, there will be spasm of the hand muscles. Here a typical sign is there, like that. This is metacarpal bone. This is phalanx. There is a flexion of metacarpal bone like that, and extension of interphalangeal joints. Okay, interphalangeal joints. This is the metacarpal bone. This is the phalanx. So there will be flexion in the metacarpophalangeal joints and extension in the interphalangeal joints. Okay, this is the thing. This pressure you have to increase above the systolic pressure. Keep it there. Within 3 minutes, the patient will have this symptom. There is flexion in the metacarpophalangeal joints and extension in the interphalangeal joints. Okay. Now, in clinical question, it will come like that. one patient of 18 years brought to the emergency with the history of respiratory distress, convulsion, then spasm of the limb muscles. Okay, there is agony, there is sweating, there is palpitation. On investigation, it was found that anything will be given, hemoglobin will be given, blood glucose will be given, along with that calcium will be given. Remember, her calcium, his or her calcium is found to be 7 mg/cent. Okay. Now, what is your diagnosis? What is the molecule responsible, or what is the cause of this disease? Then what is the, how to prevent the disease? How to prevent the disease means what you will ask her to take. Okay. Now, how it is regulated in the blood? What is the treatment of the case? Okay. So this you will get, you may get. So treatment, rest of the thing we have discussed. It is due to, it is a disease called tetany due to deficiency of calcium below critical level, below normal level, but up to 8 mg it will not produce any symptom. So they may ask, what are the signs produced due to deficiency of the molecule? Now treatment is calcium gluconate 10%, all 10% calcium gluconate 10 ml will to be given intravenous in 10 minutes. Okay. Now followed by maintenance dose. Maintenance dose can be given intravenous also. In a next drip you add calcium gluconate, infuse slowly, keep her admitted and infuse slowly. Or during discharge you have to give vitamin D and calcium. These are the maintenance dose. Okay. So this is the clinical case oriented question. Hypercalcemia, when it goes up to 11 mg per deciliter, occurs in hyperparathyroidism, characterized by muscle weakness, loss of appetite, constipation, and problem is when there is increased calcium in the blood, there may be renal calcification. Okay, number one, there is stone formation in the renal tubule. Recap: defective calcification due to low vitamin D, renal rickets due to damage of renal tissue leading to low calcitriol synthesis and does not respond to usual dose of vitamin D. This is also called vitamin D resistant ricket. Treatment is high dose of calcium and calcitriol. Osteoporosis, in case of elderly people, due to age, there is less secretion of calcitriol, less formation of calcitriol, and that will cause demineralization of bone. This also happens in predominantly menopausal women. Okay, due to the decreased estrogen level. So in treatment, estrogen is given to those menopausal women with calcium and calcitriol supplementation. And in case of male, high dose of calcium is given with calcitriol. Now, in maintenance of blood calcium level, we have seen three different ways. The fastest action is taken, the fastest action which is undertaken is renal reabsorption of calcium. But quantitatively it is very minimum. That's why the next important step is demineralization of the bone. Okay, it comes a bit later, and this is very important, and this is the major activity taken to maintain the serum calcium level. So, in short, this is the calcium metabolism, and you will get question from this, and read it nicely.